Hello, and welcome to It's Your Lymph, a podcast about all things immunity, health, beauty, and longevity. I'm your host, Lisa Levitt-Gainsler, and I've dedicated my entire career to working with people's lymphatic systems because the results are nothing short of astonishing. Come along as we reconnect to the flow of life and learn how to harness the power of lymph. Hi, everybody. I'm so excited for this episode of It's Your Lymph. My very special guest today is Dr. Ketan Patel. He's an MD, plastic surgeon, cosmetic reconstructive surgeon, specializing in microsurgery of the lymphatic system. He is at Cedars-Sinai Medical Center, and he was previously at USC Keck School of Medicine for about 10 years. So I know you're going to love this conversation. Welcome, Dr. Patel.
Thanks for having me.
I'm so happy to have you. The last we met, you organized a dinner for a bunch of certified lymphedema therapists right before the pandemic. And it was so beautiful to bring a bunch of us together. I always like to start with a couple icebreaker questions. First of all, what's your favorite place you've traveled?
I would say this past summer, I was in the south of France for about 2 weeks for one of my very close friends' weddings. And my wife and I were able to go along the coast and visit several of the cities. I thought that was pretty magical. And it was also somewhat nice to leave the kids behind, I guess.
I was just about to say, I know you have kids, sans kids. That's why it was so magical, even though traveling with kids is lovely.
Yeah, exactly.
Next question. If your lymph could talk, what would it say, Dr. Patel?
Change your diet habits.
Change your diet habits. Spoken like a true doctor.
Yeah. Change your diet habits and lay off the wine.
Thank you so much. One of the reasons why I also wanted to do this podcast, besides having you to talk to, was what I want listeners really to understand is how to engage their lymphatic system, improve their lymphatic health, and how it can be so simple, right? Just even a diet change can be so beneficial to move lymph. So I appreciate your honesty. I think we're all human and go through those peaks and valleys there. All right, last question. Let's see if you have an answer to this last question. What's your favorite self-care practice? Do you have a self-care practice?
I mean, most of it is to protect my longevity, but I do, personal training and a lot of stretching, and a lot of it's based on making sure I can continue to operate for another 20 some years.
Exactly. Good. You take care of the physical body.
I mean, the stuff we do as at least microsurgeons, they're long cases and kind of demanding on your body. And it is no different than a sport. And, I train residents and fellows, and we talk about the sport of surgery. And there is a fitness component to that, in addition to dexterity and, conditioning and things like that.
I'm so glad that you do teach your fellows that, because you stand on your feet for how many hours a day when you're doing a surgery?
Yeah, no, I mean, it just depends the type of surgery, but, like just 2 days ago or 3 days ago, we did a surgery. It was 12 hours. And it wasn't all standing, but it is demanding to the, thoracic, lumbar, and cervical spine because of fixed neck positioning, looking down, sitting, standing. There's all these different things that have a lot of demand on your back and neck and core.
Please tell us. This is where I want to get into your background, what you studied. Definitely bring in your expertise in moving into lymphatic surgery. Please tell us about you and your story.
It's interesting. So I did medical school probably at Indiana University. It's about 30 minutes from where I grew up. Huge medical campus in Indianapolis. And I connected very early on with who then became my mentor and kind of still is, a heart surgeon, cardiac surgeon. Did a lot of research as it relates to ischemia, reperfusion, injury to the heart and lungs. And during that time of trying to figure out what to do with the rest of my life, there is a bit of a audition in some ways. You try out specialties and see what you connect with. And for the longest time, I thought I wanted to do cardiac surgery. And that slowly shifted to neurosurgery and all these other specialties. And the one thing that fascinated me was reconstructive surgery. And so it's interesting. The thing that brought me to like plastic surgery was microsurgery. And sure enough, all these years later, I'm still doing it. Because what tends to drive medical students into what they're interested in usually isn't what they end up doing. Usually ends up being something else. many times. But, had an interest in microsurgery back as a third, fourth year medical student, and was fortunate enough to train at Georgetown Medical Center and did my plastic surgery training there with some of the very well-known reconstructive surgeons in the space of the extremity as well as breast reconstruction. And then after 6 years in DC, had a strong interest at that time during residency in extremity and breast surgery. And I wanted to take it one step further. I did a dedicated year of complex microsurgery in Taiwan, actually. So I moved to East Asia and lived in Taipei for a year, trained with some of the really godfathers of the specialty there in microsurgery. And it's interesting, at that time, this was in 2013, 2012-ish, 2013, lymphedema surgery wasn't really in the United States at that time, or if there was, there's one or two people like kind of dabbling in it. And one of the mentors who I met in Taiwan, had been doing lymphatic surgery for a number of years. And I was with him and seeing what he was doing, and I was a little confused, didn't quite understand what it was. And it just piqued my interest, actually. And so that's where it all started. So I just developed an academic interest in trying to figure out what he was doing and learning about it, and would go to the library because lymphology as a medical specialty in some ways isn't really owned by anyone. It's not taught in any residency. It's not taught really in medical school. So it really exists in the basic science world.
Right.
Like people in labs. So I went to the library at that time while I was in Taiwan, pulling books on lymphology out of this library and just trying to learn it myself. And every time I read a book on lymphology, more questions started coming up. And I would ask my mentor, and we just came up with all these research ideas and thoughts. And so we started publishing stuff and doing studies. And at that point, I was like, this is really fascinating. And him and I both kind of came to this conclusion. I was like, oh, we should write a book about this. So we published the first textbook on lymphatic surgery. Now it's probably been 7 or 8 years, but we put it together.
What's it called?
Principles and Practice of Lymphedema Surgery.
And how do we get that? Is that something the layperson can get?
It's a medical textbook. We created it because what we were seeing is, just like people like me, we had the skill set to do these surgeries. We just didn't understand the specialty. So the textbook is meant for a capable microsurgeon to pick up the textbook, go through the whole 200 or 300 pages, and be able to offer lymphedema surgery or surgery for the lymphatic system after reading this book. So they already have the skill set. It's just a matter of the knowledge base. So it's meant for plastic surgeon, microsurgeons to develop lymphedema surgery. It's not really for the layperson. You surely can buy it. There's a lot of great videos. It's on Amazon, published by Elsevier. We're in our second edition, actually, which came out a few years ago. It's very expensive, as you can imagine, because it's a medical textbook, and it's highly technical. That's what prompted it. It's just the curiosity, and I thought it was very fascinating, and it became a big part of my practice, part of, when I came to LA, there wasn't a whole lot being offered for lymphedema. So I took it upon myself to kind of develop something out of nothing. Yeah, we're trying to add some level of sophistication regionally to deliver lymphedema care.
Okay, so can you give our listeners, they know about the lymphatic system through me, but I would love for you to, as a doctor, give people a basic understanding of the lymphatic system. And why do you think we aren't taught about it?
We're not taught about it because up until within the last decade, we had no way to see it.
That's what I say. So I'm glad I'm validated by you.
Yeah, we had no idea how to see it. We didn't have the instrumentation or technology to identify what was going on because lymphatic structures are extremely small, right? So lymphatic vessels are traditionally under a millimeter in size. They look like little pieces of string. So they're very, very small. And so you just needed technology to be able to visualize the lymphatic system, manipulate the lymphatic system. And now we're able to do that. When it comes to like surgery, so I think that's why it hasn't really been studied so much in the medical specialties realm. And it has sat in the basic science world, like animal studies and scanning, microscopy and stuff like that. And I think that's probably the reason. And if you were to go on PubMed and Google lymphatic treatment or something over the last 20 years. I mean, it's a sharp increase in number of studies. And so
Yes.
you're seeing a specialty develop in somewhat of its infancy.
Which is so cool, which is what I tell when I get asked to speak in high schools. I always say, if you are looking to make a breakthrough, go into lymphatic science.
Yeah. Oh, definitely. There is so much we have no clue about that we're still trying to figure out. And then the first question, kind of my version of what the lymphatic system is in some ways.
Yes.
And I go through this with patients a lot, and I'm sure you've talked to people about what the lymphatic system does. We've got an immune component to the lymphatic system. And the analogy I use, as the heart being central, you have vessel systems in the body. And there's 3 vessel systems: arteries, veins, lymphatics. And the transition from artery to vein, meaning oxygenated blood to deoxygenated blood, the cellular respiration at the cell level. Arteries come in, deliver blood. The cell processes it. After it's done processing it for energy, oxygen, etc., the blood byproduct is whisked away with the venous system. But there is a exchange, and that exchange creates fluid. That's lymphatic fluid. But when we look in the periphery, most of that fluid exists and starts the distal extremity and needs to get back to the heart, such as the vein blood does too.
I'm going to just pause. Distal, for people who don't know what distal means, further away from the heart, right?
Further the edges of your body.
Yes.
And so when we talk about the extremity, it's your toes and your fingers, essentially. And so if blood and lymphatic fluid originates there and it has to travel centrally, the veins carry blood and have valves, and then it carries blood, and the propulsion of that is kind of in an anti-gravity manner with the help of veins as well as muscle movement. Lymphatic systems have kind of an intrinsic pump. It pumps the fluid via like a intrinsic, almost like an intrinsic motor to the actual lymphatic structure. The big difference in the lymphatic system and the veins is that for the purposes of what the lymphatic system does, that fluid has to go by way of lymph nodes to get processed and checked. And so you can see when you have an extremity cancer, for instance, and those cells find their way into the lymphatic system, well, it's getting processed in a lymph node. Those lymph node structures then see those cancer cells and get hyperactive and start tackling in. So that's the reason why lymph nodes swell when you have cancer, is because they're overactive. They're catching cancer in those lymph nodes. The same with infections. When you have infections that find their way from an extremity, that's why your groin or your armpit lymph nodes will swell up, is that the lymph nodes go into hyperdrive and start tackling the infected cells that come by way of it. So the analogy I frequently use is highways and toll booths. The lymphatic system kind of works that way. There are highways, there's toll booths, there's checkpoints that occur on its passage toward the heart. So when we get in the distal extremity, that's kind of what it is. So it checks the lymphatic fluid for cancer cells, infections, but also maintains some level of fluid drainage, homeostasis in the fluid compartment. And a lot of things can affect that, right? Like salt intake, altitude, et cetera, et cetera. There's lots of things that can affect that component. When we get centrally, things change. Lymphatic system functions to help with digestion, to help with transport of various fluids to the livers and kidneys and things like that. And the consistency of the lymphatic fluid changes. A lot of people think of lymphatic fluid as being milky substance. It only becomes milky once it traverses through the gut.
Right.
It's extremely clear. It looks like water when it's into the extremities because there's no cholesterol and food being processed, right? So the lymphatic system then goes through centrally. Everything comes centrally, and then it dives into the central system, which is the vein and heart here in the neck. So everything collects in the neck, right? We do get some processing from the peripheral lymphatic system into the central vein system at the lymph node level. And we utilize that relationship in surgery. That's why if you get your thoracic duct or injuries to these regions, your whole body doesn't swell. It doesn't always happen.
And when you say these regions, you're pointing to your neck. So you're saying if somebody gets an injury to the neck, they don't swell in the extremities?
Sometimes they don't. And the reason is that we do get some central processing of lymphatic fluid at the lymph node level, which exists in the periphery.
Right.
So it's not all dumps in it. Like 50 to 60% of the fluid dumps in the neck. The rest dump into the central circulation at the little lymph node level. So I don't know. Does that explain?
So good. It's so good. It's so good because I talk about it a lot in this like very metaphoric high level. And I just love our listeners to get a little bit deeper into it from you. So I guess my question then is, if it's sort of like another circulatory system of the body and it's the vessel network is twice as vast as the blood network, how come we aren't taught about it in schools? And some of that you may have answered about that we couldn't see it, but we know it's there. And also we know that the spleen and the thymus and the tonsils and the adenoids, they're lymphoid organs. But doctors rarely say that. When they talk about the immune system, they rarely say also the lymphatic system. And that's what I'm always like, I'm a big pusher. I'm like, I want every doctor to just say lymph before it gets to the point of cancer. So many people only hear of lymph until it gets to the point of cancer. But there's so much you can do, even like you were talking about with diet, exercise, to help your lymphatic system earlier.
Yeah, absolutely correct. I only can see the world through my lens. I mean, in the last 10 years, I feel as though there's more recognition, and it's partly just because of the company I keep and the stuff we're doing. But I don't know, but I feel as though people are getting behind the idea of recognizing the lymphatic system. I mean, it always tends to be in the setting of cancer care or a damaged lymphatic system, not necessarily in the realm of what you're talking about, which is more like wellness and lymph wellness. So you don't see a lot of that. I think a lot of that information, to be honest, exists in you being the lymphedema therapist or lymphatics therapist. It sits in your guys' court, to be honest.
Right.
And I think a lot of people consider our therapy colleagues who are, CLT or certified in lymphedema treatment to be the experts.
Mm-hmm. Yeah, we're trying to push it early. So I want to talk to you about lymph nodes, lymphatic surgery, the type of surgery you do. But before I do that, talk to us. Often when somebody gets diagnosed with cancer, let's say it's breast cancer, they check to see if it's in the lymph nodes, and then they remove the lymph nodes. Over the time that I've been practicing, they develop sentinel node biopsy, which means instead of removing 30 lymph nodes in the axillary region, they'll sample maybe 2, or sometimes they do intravenous dye during a mastectomy to see how many lymph nodes do they have to remove. So before we get into your reconstructive microsurgery, talk to us about why do they need to remove lymph nodes? And what's your position on what you see with lymph node removal? Because that's what can lead to lymphedema.
Yeah, no, it's an ongoing topic, discussion, and innovation, to be honest. Full disclosure, I am not a surgical oncologist, so I live in the oncology space peripherally. I defer kind of complicated and current thoughts and trends to our oncologist, the breast oncologist, but I see what's going on. And being at Cedars, actually, who have really sat at the forefront of a lot of this. In fact, a surgeon I work with, is very much credited with the development of the sentinel lymph node biopsy for breast cancer, Dr. Armando Giuliano. They are always at the forefront of the movement of what to do in what scenario. So as it stands, the reason why lymph nodes are removed, from my understanding, for the most part, is risk stratification for cancer treatment. And so when you have these large studies where they take groups of patients with similar diseases, they apply treatments and figure out survival. And in order to do that, a lot of our current knowledge related to any cancer, frankly, is about the lymph node status. And that changes your cancer prognosis. So not only lymph node status, but also metastatic lesions, right? So if someone has a cancer and they get a PET scan and something shows up maybe on the spine, well, the reason they go and biopsy the spine is to figure out if that actually is cancer, because it will change what they do next. It's the same with the lymph nodes. Now, that being said, with imaging and the way they're able to sample lymph nodes, things are changing. As I said, I live in it peripherally, but I do see it where lymph nodes aren't necessarily removed. They're evaluated and followed during the course of treatment. So you are seeing less axillary surgery year after year. I see the needle moving that way, where eventually people probably with axillary lymph node involvement may or may not get those removed in the future. I don't know, but I think there are studies showing that you can leave positive lymph nodes and just use chemotherapy to treat those lymph nodes.
Mm-hmm. And then the reverse mapping. Have you worked with somebody or seen surgeons? I know at Learn conferences, Lymphatic Education and Research Network conferences, there have been breast surgeons who talk about reverse mapping where they inject dye to see do those lymph nodes light up during surgery, which is another, question about should you take them or not take them. And have you seen that?
Yeah, I mean, I think you probably attended the meeting I hosted, and the person credited for developing that technique, Suzanne Klimberg, we invited her to actually talk about that topic. It is a concept that makes a lot of sense. Is it being routinely used right now? No, I don't think so. I think there is momentum that people are using reverse mapping from the oncologic side of things to avoid, I guess for your listeners, essentially the concept of doing selective lymph node mapping is in breast cancer care is that the lymph nodes in the armpit have shared drainage from the breast and the arm, both. So if you inject the arm, you can identify lymph nodes that drain the arm and not the breast. Sometimes they're shared, but sometimes individual lymph nodes drain the arm and not the breast. So the idea is save the ones draining the arm and leave those alone and just select and take the ones draining the breast. So that's the whole concept. Theory being that if you avoid taking the lymph nodes that drain the arm, you're probably going to drop the incidence of developing lymphedema. So it's all based on the fact there's shared drainage.
Right.
So reverse mapping is a little bit of a misnomer. There's nothing reverse about it. It's kind of a selective lymph node mapping.
Right.
It's probably more appropriate.
Okay. So talk to us now about the type of lymphatic microsurgery that you do. I know there's so many different kinds. There's reattaching lymph vessels or lymph node transfers. And there's lots of acronyms. So spell it out for our lay listener, please.
Yeah, and it's this discussion I have with patients all the time, is if you simplify it, there's really only for the most part, three types of surgeries that we can do for lymphedema. And you touched on two of them. One is lymph to vein bypass surgery. And I use that highway analogy a lot, which, you have two highways leaving your extremities. One's the lymph highway, one's the vein highway. If you've got traffic on one highway, you're going to naturally get off that highway and go to the highway with no traffic. So we create those connections. We create those bypasses from one highway to the other.
And before you move on to the next, how does it get damaged? How does the lymph vessel network get damaged?
So the thing with the lymphatic system, which is a little different from other systems in the body, is that, as I mentioned, it's a kind of a one-way highway from the tips of your toes to your heart, but by way of a bunch of lymph nodes. When those lymph nodes are removed for cancer, right, or tips of your fingers to your heart, when those lymph nodes are removed for cancer, now that toll booth becomes out of order. And what happens when you're on the highway, if the roads, there's construction or the toll booth's out of order, guess what? All the cars back up on the highway. So that's what happens on that lymph highway, is that all the fluid backs up. And so now you've got a lot of traffic on that highway. And so when the big difference between the lymph system and the highway analogy is that when the traffic dies down, I guess, and the cars start moving, the highway's still intact. The difference in the lymph system is that when that fluid just sits in the highway, now the highway starts deteriorating. So that's why the lymph vessels become damaged, is that it just has too much fluid in it over time. And so you get this snowball effect, or downstream damage as a result of an upstream problem.
And can that happen through radiation also? Does that damage lymph vessels?
Yeah, it does.
That's what I said, yeah. Some radiologists don't think so, and I'm like, actually it does.
Yeah, it does. I mean, radiation, it causes fibrosis at the cellular level, and, lymph vessels are fairly elastic, and they're very, very sensitive to inelasticity and changes of the environment that it's around.
So can the lymph vessels get damaged through cosmetic surgery, regular surgery, liposuction?
Yeah. In fact, today's Thursday. So yesterday, I actually operated on a patient who had a thigh lift and developed a lymphocele and lymphedema.
What is a lymphocele for people who don't know what lymphocele is? And most of my people know lymphedema, but just if you could give those two definitions.
A lymphocele is a collection of lymph fluid that forms, and it looks like a golf ball, essentially filled with fluid in it. And it develops when there's a lymph leak. When you cut a lymphatic vessel, it drips like a faucet. And if it doesn't seal off on its own, which, lymph vessels are damaged routinely during surgery because you can't see them. So anytime you cut through skin, they're everywhere. So people are cutting them all the time. And usually it's without any consequence because there's a lot of redundancy in the system, particularly centrally. Problem is when that lymph vessel doesn't seal off, it just keeps dripping, 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 and it causes a ball of fluid. And when that ball of fluid occurs over time, the body will form a little shell around it, and then you can't really drain that ball of fluid. You have to cut it out. I mean, there's a lot of medical words we use related to the lymphatic system. One of them being lymphocele. Another one, which you may or may not have heard of, is called lymphorrhea.
Oh, yeah. Let's talk about it.
Lymphorrhea, yeah, that's a real problem. Lymphorrhea is essentially drainage or leakage of lymphatic fluid through the skin.
How does that happen?
I think it's an interstitial pressure thing. It's a pressure within the soft tissues. And once you hit a critical number, the skin can't act as a barrier and it just breaks. So you tend to get lymphorrhea in really advanced cases of edema.
Not just lymphedema, but edema and those wounds.
Yeah, it can be edema from lots of different causes. But lymphorrhea typically, just by definition, is supposed to be lymphatic fluid, not necessarily other types of fluid. But so we tend to see it in more advanced cases of lymphedema, which essentially lymphedema is just, by definition, is essentially stasis of lymphatic fluid within a region. It doesn't really matter what region. It doesn't necessarily need to include an entire extremity, or it can be localized. It can be just regional to a specific quadrant of a place, but it is typically caused usually by some sort of traumatic event, a surgical event, or from cancer. We have our fair share of folks that have genetic reasons why they have lymphatic issues, which is, I think most of us would agree that it's some underdevelopment of the lymphatic system. It's what we call primary lymphedema. We see, and particularly me, we see all sorts of ranges of disease entities related to the lymphatic system.
Explain for the listeners too the difference between lymphedema and edema, and how do you know the difference?
Well, your body will naturally try to accommodate when there is edema. It will try to use its systems, which is typically the lymphatic system. Again, the lymphatic system is responsible for fluid homeostasis, right? Keeping a fluid balance in the body. Lots of different reasons why people will develop swelling. Classic example, in the tail end of pregnancy, women will have lower extremity swelling. The reason why the lower extremities tend to swell is that typically as a baby is being developed, as it gets bigger, it causes a mass effect to the venous system or potentially lymphatic system in the pelvis, which has a downstream effect to the lower extremities. But that's edema. There is not a lymphatic issue going on. It's edema because there is probably versions of lymph fluid or an inappropriate exchange of the fluid homeostasis going on. So what I tell folks is edema typically can be transient, meaning it can go away. Lymphatic insult, though, typically doesn't. When lymphedema sets in, when the lymphatic system becomes deranged, it stops working effectively. It doesn't reverse itself, in my experience.
Right. Without intervention. That's what we typically call like stage 0. Will the lymph fluid go up and down without intervention? And when it gets to that stage 1, it requires intervention, be it compression stockings or compression bandaging or lymphatic drainage, etc. Okay.
Yeah. So what I tell folks is that a surgical insult can result in edema. A sprained ankle can result in edema, right? Like healing. Your lymphatic system may or may not be affected. The problem is that when edema sits in for a long period of time, it will cause a strain on the lymphatic system. So that's why I tell everyone, if you get a sprained ankle, get the edema out of there because you don't want it to progress to lymphatics.
And how do you tell them to get the edema out?
The compression. You have to use some version of compression. Personal experience, like my wife with our first kid had severe edema of her lower extremities, and I was sitting there wrapping them and I was like, you just got to keep the fluid out of your legs. Because the last thing I want, because I have actually treated 3 patients who developed chronic lymphedema that was pregnancy induced.
Do you think they had a lymphatic genetic component in the family?
Yeah, who knows?
Who knows? Yeah, I get people who, ask me all the time or have come to me, when they're pregnant and they really want to work on their, do lymphatic massage for their legs when they get that bilateral swelling in the legs.
The one thing that I think that is underappreciated is the fluid allowed to sit under the skin in and of itself causes the damage.
Right. Because it's sort of like putting too much pressure on a bridge, right? Like a bridge collapse in a way.
Correct. Like a very unstable wooden bridge.
Right.
The lymphatic system, you look at it weird. You just give it a funny eye and it will shut down on its own. It's very fragile.
So this is where I get into working with somebody who's had facelifts, right? And so they cut behind the ear often or up in the head. And, you have so many preauricular and retroauricular lymph nodes around the ear and the neck. And you're just but so many of them don't develop head and neck lymphedema. How is that?
Yeah. So one thing to mention around incisions.
Yes.
So you make an incision, you cut right across here. I'll cut 5 lymphatics at least, right? I go down to the bone, we'll cut it. The one thing is when you reoppose soft tissue, the lymphatics will reconnect. They will reconnect. You see that in the basic science literature. And it just like we see with skin healing, the lymphatics will heal. I mean, there's lymphatics in the skin. So they will connect and reestablish flow.
And at the lymph vessel level.
At the lymph vessel, subdermal lymph vessel level.
All right. So we talked about the first type of surgery, which was the lymph vessel surgery. You said there's 3. Tell us the other ones now.
Yeah. So the second one is a lymph node transplant.
Mm-hmm.
And the thought behind that is, and I kind of mentioned this earlier, is that there is some movement of lymph fluid from the periphery into the central circulation at the level of the lymph node. And the reason is the lymph node itself has its own circulation. So we utilize that relationship to transplant a lymph node to an area that has fluid with the hope that as you get healing of the soft tissues, those connections create a passage to that lymph node, and the intrinsic circulation allows that fluid to be siphoned off into the central circulation. So that's the second surgery.
So do you do a lot of that lymph node replacement transfer to axillary lymph nodes in the armpit? Is that the majority of where you're doing it? And if so, where do you get those lymph nodes from so you're not creating another problem somewhere else?
Yeah, that's a great question. So in the upper extremity, there are 2 different places that I'll put lymph nodes. One is where the lymph nodes were removed from.
In the armpit, let's say.
In the armpit. And the other place is down in the arm.
Right, behind the elbow. Right.
Well, I go right in front of the elbow, kind of in the I shouldn't say the arm, the forearm.
The forearm,
just
okay.
like here. And along the same lines, and we talked about the snowball effect, right? So you take out lymph nodes from the armpit. Well, it's good and fine if the lymphatic system then just stops and then it can restart. The problem is it doesn't. It starts crumbling behind. So if you put sometimes you put the lymph nodes in the armpit, well, guess what? The fluid's not getting there.
Right.
The fluid doesn't get there because the system is all diseased now. So that's why I tend to put lymph nodes closer to where the actual fluid is sitting.
Now, when you do that lymph node transplant, are you also having to repair lymph vessels along the highway?
I mean, it would be nice, but a lot of times those patients tend to have more advanced disease, and so there isn't any lymph vessels you can find.
Wow.
But occasionally we do. If we can find them, we'll do them, yeah.
And where are you getting the lymph vessels from to place them in the axillary or in the forearm?
The lymph nodes, you can get them from a number of sites, and that's a little bit of kind of surgeon preference. Some of the sites include taking the nodes here in the supraclavicular fossa, just right here in the neck region. There's a few lymph nodes you can take that are expendable in that region.
Wow.
The superficial groin lymph nodes, which drain the lower abdomen, not the leg. So you can isolate those. You can take lymph nodes from kind of back here in the back of the armpit, which drain the back region. You can take lymph nodes from intra-abdominally, like in the stomach, near the stomach.
Like the mesenteric lymph nodes or something. Is that what you've taken?
There's mesenteric lymph nodes and then omental lymph
Oh,
nodes.
the aumento. Okay. And you have enough that won't cause a backup or a problem in those regions.
For the ones in the stomach or in the abdomen, no, there's plenty of redundancy there. When you go to the base of the extremity, anytime you take lymph nodes from the base of the extremity, there's always in the back of your mind a little worry that, the last thing you want to do is cause lymphedema. And so
Right.
we have translated as a specialty, we use a lot of these selective lymph node mapping or, reverse lymph node mapping as a way to select specific lymph nodes and leave specific lymph nodes.
Mm-hmm.
So that's what we do anytime we take lymph nodes from the groin. You have 3 packets of lymph nodes down in the groin. You got 2 that sit near the vessels from the thigh, and then you've got a few lymph nodes that sit well above it, which drain the lower abdomen. So we take the ones that are above it.
Mm-hmm.
But as I mentioned to you, the lymphatic system is very fragile. So even in the process of doing extremely safe and identifying what you need to identify, things can happen that you don't anticipate, which would be lymphedema in this case.
Okay. Third surgery.
Third surgery is debulking.
Right. Oh my God. Talk to us about it.
Liposuction or excising out extra tissue.
So how much of that are you doing?
A decent amount. I mean, I break up lymphedema into its components, right? So another thing underappreciated is that I think most people think that lymphedema is just a retention of extra fluid. That's the first part of it. The problem is, like I kind of mentioned, when the fluid is allowed to sit there chronically under the skin, it causes a lot of secondary effects, which include scar tissue fibrosis, but the other thing, which is fat hypertrophy. So it causes fat to swell and get bigger. So lymphedema is characterized by both fluid and fat. So the liposuction addresses the fat component.
Now you're doing the debulking and liposuction in a different way than maybe some other liposuction at an aesthetic, these aesthetic med spas, at least all over LA, are like, oh, come in and we'll do, a little lipo here and there. But what you're doing is different because you're trying to spare the lymph system and repair it at the same time.
Yeah, we tend to do it in a way that we hope causes the least subcutaneous destruction of remaining lymphatic tissues. It's really hard to know that for a fact. We just try to apply those thoughts in doing that. In cosmetic liposuction, your thoughts are a lot different. Like what you're trying to achieve is different. And so it is a different type of surgery and how you actually kind of do it. The principles are the same, but what you're trying to achieve is different.
So talk to us. With the clients that you're getting, a lot of them have had lymphedema, breast cancer related, or ovarian cancer or reproductive organ cancer. How do you know if somebody is a candidate for surgery?
I would say in the setting of breast cancer related lymphedema, every patient's a candidate for surgery, to be honest.
Yeah, I love this conversation.
Every single patient.
Right.
Now, the only thing that would prevent them from being a candidate maybe is some other comorbidities, right? Like they're too high risk from a heart, lung, kidney problem. Something like that. But strictly speaking, all else things being equal, if you have breast cancer related lymphedema, even if it's extremely early or extremely late, we still have the ability to do one or multiple of those 3 surgeries.
And I just want to say to people, 30 years ago, this didn't exist. And the treatment
15 years ago, it didn't exist.
Correct. 15 years ago, it didn't exist. And, the treatment for so long was like you were talking about wrapping your wife. We wrap people in these short stretch bandages that are sort of like these big, huge, cumbersome casts. And and the fluid comes back the minute you take those bandages off, maybe not the minute. Sometimes it's a month later, a year later. They're sort of in and out of PT being mummified. So this is such an exciting breakthrough. And I do wonder, shouldn't almost everyone just get it after they've had lymph node removal? Not that everybody wants to go back into surgery.
So the lifetime incidence, depending what studies you read, lifetime incidence after axillary lymph node dissection for developing some version of swelling is close to 50%. It's so high, but on the flip side of that, there's half of the people don't have any issues. So, from the healthcare utilization component, you got to weigh those. Doing surgery for people having symptoms versus
or if you have symptoms early.
yeah, so along the same lines of everything I've told you about the development and the natural history of lymphedema and the downstream effect, probably guess that if you surgically treat lymphedema when it's early, your results are naturally going to be better. But I do say, and I say this a lot to patients, it's like even if I give you just a few % chance of having some improvement, is that something you're willing to have surgery for? This isn't something I'm mandating you have to have. This is a choice.
Right.
I don't do life-saving procedures. It's life enhancement. It's to improve your quality of life, improve your day-to-day living, garment-free time, your decrease in infections, which can be life-saving, actually. We treat patients who have chronic infections a little bit different.
Oh, so just for the listeners' edification, what he's referring to is people who get lymphedema. They're at a high risk of getting cellulitis, which is a systemic infection that can spread and be life-threatening. Unless you got to get on IV antibiotics or regular antibiotics.
Correct. And we have our fair share of patients who, it's not a lot, it's a minority, 5% maybe even less, that require frequent use of antibiotics in a given year.
Wow.
Sometimes a handful of folks are on it lifelong. They get so many infections that they actually every single day have to take antibiotics. So that's a thing.
Yeah. So, all right. So the thing that would seem to make most sense to me is if somebody is having symptoms of lymphedema, to come in, schedule an appointment, and look at surgical options on the early end before it gets into the stage 2 or 3 lymphedema, where it's really fibrotic.
100%. And I think, we're so used to the natural course of what we think of surgically. We think of it the same way in lymphedema treatment, which is as things get worse, indications for surgery become more clear. But in my opinion, is the reverse for lymphedema, for all the things I've already said. Is like you should actually have it early to kind of keep all these downstream things from happening, as opposed to let me try all these other things and wait till it gets so bad that I need surgery. But it's like a backwards thought process, I think.
Well, that's how I feel about manual lymphatic drainage. Let's do lymphatic drainage on people early and often to keep the lymph system moving. But, most of my colleagues weren't doing that 20 years ago. They had to wait until insurance would cover it, which is my next question. Does insurance cover this surgery?
Yes and no, because it's in somewhat of its infancy. And, I respect the views of the insurance companies because they have to think about healthcare in the entirety and utilization of healthcare dollars for various treatments. And so they have to base a lot of what they consider for coverage based on functional need. And that's also validated with research. And because lymphedema surgery is just like any other surgical specialty in its somewhat infancy, a lot of the early adopters or mavens or, the people pushing through the barriers are just individuals doing this and reporting their outcomes. And if you look at level of evidence, it's low because it's not a multi-centered, prospective, blah, 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 randomized trial, all that stuff, which is what the insurance companies want to prove that it's effective. So I get where they're coming from, but I will tell you there is a lot of momentum on the side of getting this covered. I work with these insurance companies to help them understand this a lot better over the years and helping to write policies related to coverage of these surgeries and the right indications for it. And that's the analogy I frequently use to the insurance companies is very similar probably to what happened in maybe the 80s or 90s as it relates to breast reduction surgery, where there is a functional need. Macromastia, which is large breasts, can cause a functional problem, right? Posture, back pain, neck pain, but it's not a white and black situation. There's a gray area. A certain size of breast can cause a certain heaviness that leads to functional disturbance. So at some point, because breast reductions in certain circumstances are covered by insurance, but in circumstances they aren't. And so they came up with criteria, and lymphedema surgery is no different. There is criteria to treat folks who actually have functional issues with insurance-based dollars. And so we're at that stage now. I mean, it's getting to that point, and we're at critical mass. There's enough people doing it now. And we're training more and more people to offer lymphatic surgery, and patients are demanding it. And so it's exponential growth. And now insurance companies have, their eye is on it, and they're wanting to cover it. They just need to know how to cover it. And so that's what folks like myself and others try to help them to realize, how to navigate that.
Can you tell us a little bit about the outcomes of what you see with your microsurgery?
Yeah, the surgeries, again, I think the identifying what's causing functional problems to patients and matching that up with the expectations and the reality of surgery is important. It'd be easy for me to say, hey, I do these surgeries and guess what? Their lymphedema is gone. That is just not the case. And if you hear that, it's just completely false. We are aimed at trying to improve or reset the clock a little bit on areas that are causing the disturbance. Meaning, we have plenty of folks, as you know, it's not, if you have breast cancer related lymphedema, it's not your whole extremity sometimes. Sometimes it's just this area. This area causes it problems.
He's pointing to the top of his hand.
So I try to identify what is the actual problem. Is it something we can treat or help with? And what we do, even if it helps, is it going to improve your quality of life? And you got to identify all those different things. And what is the actual the motivation of the patient? Like, okay, if a patient says, hey, I'm sick and tired of wearing compression, I'm sick and tired of getting treatment, therapy, all that stuff, I want this to be gone. Well, that's not reality. We can't actually do that. It doesn't exist. So when people have that expectation, it's, our job's to realign that with reality. And the reality is we can improve upon how quickly your hand or arm drains, how your need for compression. You still need compression. You still need treatment. You still need to be aligned with a lymphedema therapist that you can connect with on a routine basis. And so you still need all those things. But despite those, if you're having swelling that's causing the inability to write, the heaviness, it's causing shoulder problems, these are things that we can try to improve upon. So that's our aim, is to decrease the heaviness burden of the extremity, decrease the amount of waxing and waning swelling. If you have infections, to get you off antibiotics, which we can do and we have done pretty successfully, and to ideally come off compression at meaningful parts of the day. But to come off compression completely, it has happened and we are able to do it. It just doesn't happen that often. And it's impossible to predict who can do that and who can't.
Okay, so this is the part of the podcast where I ask you in and out of flow questions. So back to personal questions, Dr. Patel. What does being in flow feel like for you?
Listen, I adapt to my surroundings pretty quickly and move very fluidly. So I dodge the obstacles of life pretty well and manage them pretty well. So in flow seems like all the time. Yeah, have a good balance.
How do you do that?
Keep a good work-life balance. We cherish we love Southern California. Listen, we're West Coast transplants. We love our weekends. We're big into doing things. Our kids are into sports and things like that. And I'm an avid golfer. I love being outside. So, keeping a balance between the two is great.
I love that.
And also very particular about my schedule. So that's an important aspect of what I do. I'm pretty regimented about when I work and when I don't.
I'm so happy to hear you say that. Most doctors, can't be. And I think you deliver better results because you take care of your time.
Yeah, I've seen it too often. Particularly with this physical fitness type stuff. So, I have a physical therapist I work with for movement, trainer I work with for strength and core stability. So I'm pretty in tune with that because I got 20 some years left of operating, and I want to make sure I stay limber for that amount of time.
I love that. So there's no being out of flow for you. You can just adapt if you're feeling a disturbance in the force.
A disturbance in the force, yeah.
Would your wife say the same thing?
What she would say is nothing seems to ever bother him, which is probably true.
Oh, I love that. I love that. That is such a beautiful way to end. So, beautiful listeners, I'm sure you are all taken with Dr. Patel and you see why I wanted him so badly on this podcast. So please tell us where our listeners can find you and where you're located and anything that's coming up for you that you want people to know about.
Well, I'm part of the Cedars-Sinai health system, which for me individually have offices both in Tarzana and Cedars, Maine, which is, in the center of LA, essentially. Our goal, and one of the reasons I was excited to move over to Cedars when they recruited me was and it's been something I've been saying and at the top of my lungs for years, is regionalizing healthcare in some ways. And being LA, being 100 different little silos all over the place, I think it becomes even increasingly important to regionalize healthcare. And Lisa, you're part of it. Our affiliate network that we kind of started pre-COVID, we're bringing that back. Now that I'm a little more firmly got my feet on the ground, I've been at Cedars now for about 5-6 months. So you'll see that in the works related to lymphedema. The inevitable goal is to be able to offer a level of service across the health systems, which is, essentially 5 hospitals. And they are perfectly positioned all around Los Angeles, whether it's the Valley, the East Side, or the beaches, or the South Bay, or the center of LA, will have roughly the ability to offer services across that. And that takes some effort, though. We have to, as I said, it's a surgery and lymphedema therapy complement each other. So being able to offer that, we have to bring those two together on the same page. And, that's something I've worked on for years. The other thing is, I don't just do lymphatic surgery.
That was going to be my next question. When would people come to see you? Yes.
Yeah, no, I mean, I still, reconstructive microsurgery is still the thing that excites me. So it's not only lymphatic surgery, it encompasses, flap-based breast reconstruction or any breast reconstruction, or lower extremity devastating traumas, facial reanimation, we do that, peripheral nerve. So it encompasses a huge spectrum of disease entities that we're able to treat using kind of sophisticated surgery. But I'm at Cedars. We have a full complement of other surgeons as well that have expertise in all these different realms. So, Cedars, over the next 5 to 10 years, we'll have a pretty strong force in numbers as well, to be able to offer all of these different services, including obviously lymphatic surgery. So,
well, thank you so much. It's been such a pleasure to have you, and I look forward to seeing you down the road at another lymphatic event.
Yeah, of course.